My name is Winnie Armand, and welcome, and thank you for joining us. I'm the Associate Director at Mass General Center for the Environment and Health, and we are doing these monthly webinars in a co-sponsored fashion along with the Institute of Health Professions Center for Climate Change, Climate Justice, and Health, as well as the Brigham and Women's Hospital. So I'm honored to introduce our speaker today, Dr. Rose Goldman. Dr. Goldman is an associate professor of medicine at Harvard Medical School and associate professor of environmental health at the Harvard T.H. Chan School of Public Health. She started the occupational and environmental health program at Cambridge Health Alliance and served as the founding chief of the Division of Occupational and Environmental Medicine. Dr. Goldman's career combines clinical, occupational, and environmental medicine with public health and education, and bridges the clinical practice with public health, targeting the integration of preventing, recognizing, and treating illnesses related to work, environment, and most recently, climate. We're so fortunate to have Dr. Goldman join us today to share ways to provide practical guidance and potential interventions for our patients on these issues. Thank you, Dr. Goldman.
Thank you, Wen. I really appreciate that introduction, and I'm going to share my slides and get going here. Okay, can everybody, I'm hoping everybody can see these slides. And also, if you have any questions, if you could put them in the chat, I will be saving some time for further comments and interchange after some of the presentation slides. So my talk today is really about burning fossil fuels, climate change, and workers, but something practical. What does the clinician need to know, and what are some possible interventions that we could do? In terms of disclosures and disclaimers, I do write topics for UpToDate, and I get some royalties for that. In addition, some of my work in education is partially supported by a grant for the New England Pediatric Environmental Health Specialty Units that I also helped to find and run with Alan Wolf and Marissa Houtman. And any of the opinions that you hear in this talk are really my own opinions and don't represent that of the agencies, the Cambridge Health Alliance, or Harvard University. So let me start by saying that as Wynn mentioned, I am one of these people. I trained in internal medicine, and then I went to school at Harvard School of Public Health to study more prevention and occupational environmental health. And so I'm a hybrid person, and I see myself as thinking about global issues, but actually still very much a clinician and wanting to act locally. And when I finished my training at Harvard School of Public Health, I had learned so much about occupational and environmental risk factors for illness. I was sort of shocked to realize that it never entered into history taking or into my practice or my internal medicine training. And so I wrote this initial article with my mentor, John Peters, trying to say, if we were going to figure out how to put this in practically, how would we do it? What would be a routine screen that we could do on every patient, to ask about jobs, maybe are they have any exposure to fumes or chemicals or dust, and then to think about the chief complaint and how it relates to a potential linkage to an exposure. So in my early days of doing this, my focus was really mostly on detection of underlying occupational environmental risks, maybe a bit of prevention. And that was where my focus was, those don't miss diagnoses also. And then I've evolved since that time to think more broadly about why is it that we would take a work or environmental history. And so, of course, recognizing work or environmental factors that cause or exacerbate medical illness or injury is certainly a prime one. And then the other important thing is that any early recognition of a problem and can lead to prevention or control of the problem, and also decrease exposure to others. So that's always been a very fundamental part of why I think it's so important to be taking an occupational environmental history. And it's sad to me that work and environment, which is one of the social determinants of health, always seems to be one that's the most frequently ignored. More recently, I've really begun to see this aspect in a even more broad and important way in the setting of climate change and COVID, which is what we do with prevention and anticipatory guidance. And that is using our clinical time to identify those at risk, using some practical strategies to figure out ways to decrease exposures and risk. And I think a lot of this really came to the forefront with COVID, and all of a sudden waking up to the fact that there were these essential workers out there having a lot of exposures, and we were not paying enough attention to them and how to protect them. The other thing is I'm a practical person. I do still work in an occupational environmental clinic, but I did primary care for over 20 years. And I wanted to say, okay, what is it that we could use in a practical way in the clinical setting? And of course, I would always encourage any advocacy actions that would happen outside the clinic. But most of what we'll be talking about today is what's possible in our clinical setting. So my concept of this occupational environmental history taking has evolved over the years. And back in the day when UpToDate decided to bring in more about primary care, I was asked to do the section on occupational environmental health. And this is how my ideas of this screening have evolved. I still think it's really key to understand what the current job or longest held job of our patients are. But I'm also evolving with this question to put in: are you concerned about any exposures or hazards at work or at home? Which I think is a really important question in general to bring up questions and concerns. And it may even bring up concerns about flooding due to climate change or disasters. But also, we've become even more concerned about the increase in heat, which we'll talk about later. And I'm advocating for including this question, both for workers and anybody in our clinic. Do you have a way to stay cool on hot days and warm on cold days? And we'll come back to this later on in the talk. So let's go to the situation of burning fossil fuels. And when we burn fossil fuels, either from the factory or from our cars, we are putting out a double header. First of all, we're putting out actual air pollutants, particulates, sulfur dioxide, nitrogen oxide, even mercury. And at the same time, we're putting out the greenhouse gases, which we know contribute to climate change. And so workers and ourselves as people who live on the planet are being exposed to both of these exposures at the same time. And in this realm of particulates, we're particularly concerned about these really small ones, the 10 micrometer and the really little ones, the PM 2.5, because these are particulates that have been associated with major increased problems, both with morbidity and mortality. At the same time, these burning the fossil fuels are putting out carbon monoxide and other greenhouse gases and leading to the warming planet and the climate crisis. So I just want to point out how little these little PM 2.5 particulates are. If you look at a hair, and these are the PM 10s, which have been associated with exacerbation of asthma, but also these PM 2.5s, which are so small, they not only get into the alveoli, but they're able to cross over the capillary alveolar barrier into the blood, which may be one of the reasons that we're seeing some of that additional adverse health effects. And these are not simple little dust particles. These are particles that are coated with chemicals, as you can see here from this graphic. And there is some thought that they are transmitting these chemicals into our body. In addition, when we put out nitrogen oxides and other volatile organic compounds, and the sun shines on them, we now have a problem of creating ozone at ground level, which as another irritating gas has been associated with many health effects, including exacerbating asthma and chronic obstructive lung disease. So if we make a summary, and I'm not going to go through the reams of research that has come out and continues to come out, that burning fossil fuels not only puts out the greenhouse gases, but also these other pollutants, which we've just talked about. And there have been many studies that show an increase in mortality and morbidity in the general population that's very well correlated with an increase in exposures to fine particulate matter. We've also seen studies that show the increase in asthma and COP exacerbation associated with ozone. And interestingly enough, over the years, the research has led to more regulation that has lowered the allowable amount of these fine particulates and led to a decrease in mortality, an increase in lifespan. We are also going to talk about the effects of the carbon dioxide on warming and climate and those health effects. But the other important thing about these exposures, which is also very distressing, is that there is a disproportionate exposure and associated health effects from air pollution and climate change on differing populations, populations that have to live closer to major highways, the populations of people who tend to work in the jobs with the most exposures, which we'll talk about, are heavily more tilted towards immigrants and people of lower socioeconomic background. And we'll see that they become part of the working population that we have some of our most concerns. So I want you to think about, if we look at this air pollution problem, think about in your own mind which workers might be at risk for these adverse effects from air pollution. If you want, you can just make a few comments in the chat. So I'm going to tell you what I think about in this situation. There are particularly the workers who have jobs outside. And when I look around, I see roofers, I see construction workers, I see the people working on our roads, landscapers, gardeners, agricultural workers. And again, thinking about, at least in our area and others, some of the people that are doing these jobs that place them at the greatest point of exposure for air pollution and heat, as we'll talk about later, are people for whom English may not be their first language, so they don't know how to advocate for themselves. Might even be teenagers doing some of these jobs who aren't well trained, and certainly agricultural workers out there. In addition, we have firefighters, and my colleague Steve Kales has written a lot about firefighters and their increased risk from working under strained conditions, fighting fires as well as wildfires and cardiovascular outcomes. We have emergency responders. I also want to call attention to athletes who are training outdoors, adult athletes, but also children and teens who could be suffering from air pollution as they try to do their running or high exertion athletics. Certainly the military, and again, going back to what I mentioned before, that there is not infrequently a disparity in the exposures and the consequent health effects. The other thing I think we need to be thinking about as clinicians is that among these workers, they also have personal health conditions that could get worse with poor air quality. I think about our patients and the workers who have asthma, who have COPD, who have cardiovascular problems, and who then go to work in a situation where the air quality is poor. So getting back to the burning fossil fuels and coal pollutants, the other issue that comes up is we not only have these particulates and pollutants coming from burning fossil fuels, but the consequence of climate change, which we will be talking about further. But if we think about the rising temperature, the effect on water and drought, we get to the problem of wildfires. And when we now have burning of not just forests, but as we've seen in a number of communities, the burning fires are burning houses and buildings. And so we're putting into the air not just organic matter, but now particulate that may contain many plastics and other materials. And so we have seen over time this deadly combination of heat plus drought, more wildfires, more severe wildfires, and an increase in air pollution. And there are workers at risk for this. We certainly think about firefighters and rescue workers, but we don't as often perhaps think about the risk of pollution, this kind of pollution, to all other workers who are working outside. Certainly those of us in the Boston, Massachusetts area think about wildfires sort of out there, out west. And yet we saw that when the wildfires arose in Canada this summer, that along the East Coast, we were inundated with the kind of smoke and risks. And now we saw that some of these workers who maybe we didn't think about having a problem with air pollution, construction workers or other workers or landscapers, but actually they were inundated with having to work in a very polluted air. So how do we help our workers, and what do we need to know about judging air quality? Because I think having a sense of what these air quality indexes actually mean and how we can use that as we advise patients or educate patients is something useful for all of us. And so we might have heard on the news, oh, well, air quality is good today, there's no messaging. And you may remember that when this happened in June, we were hearing, oh, well, the air quality is really bad. And this air quality ratings, just to let you know where they come from, we have the EPA National Ambient Air Quality Standards, and these relate to ozone, carbon monoxide, nitrous and sulfur dioxides, and these particulates, the fine particulates that I've mentioned. Fortunately, because of research, the research has driven some of these allowable levels down low. Lower than they have been before this chart was made. But you will see that for fine particulate matter, the 24-hour recommended level not to cause adverse health effects is 35. And just to let you know, over the summer, when the smoke was coming down, we were running levels, particularly in New York and Washington, D.C., that were in the hundreds. So very dangerous, particularly to people with any underlying health problems. So how can we use this information in a practical way? And one way is that we can actually see what the air quality index is anytime. I don't know if I can click on this and show it because that doesn't always work. But if you were to click on this, if you happen to have this on your own phone at wherever you're viewing, you could go to this site and you can put in your particular location right at this moment. If I look at mine. I've actually saved this on my cell phone. I see that where I'm sitting right now in Brookline, Massachusetts, the air quality index is 27, and it's probably based most on the particulates. You can save this as a handy phone app, and frankly, I have it as a phone app, and this is something our patients could have as a phone app. And if they don't have a phone app, they can listen to the news, but part of our education of the patient is saying, when you hear you're in the red zone or this zone, to be sure that they know what that means, and then to think about how we might talk with our patients about what measures they could be taking. So one of the things I'm thinking about as we apply this to the clinical setting is that we would identify workers who would be at risk levels of air pollution. And again, if we take a job history, that could be people that are working outside particularly, and people who have other health issues. And here we could be giving some anticipatory guidance. Let them know about the air quality index. Let them know about putting the app on or being alert to these alerts actually that come out from the weather department. And then maybe thinking about with our patients, just like we do counseling, and I would invite others who might have ideas about that, but I'm thinking, well, maybe if I had a patient who has intermittent asthma, but I know that they're doing a job outside and that they might be at risk for being exposed to air pollution, perhaps saying maybe you should anticipate this, use an inhaled steroid if you're going out, like some people use it before they do exercise, maybe advising people who have exercise-induced asthma, maybe running on these bad air days is not a good idea, making sure they have their medications. The other thing is perhaps with some patients, we have to have a realistic talk. Is there a way to change your job on the days where it's really bad air? Maybe taking a sick day, or at least starting a conversation or letting them begin to think about what they might be doing. So I want to move on now to that other part of the situation here, the greenhouse gases and the issue of climate change. And we know many of us have seen this chart about the impact of climate change and the issue of rising temperature, more extremes, seawater, and all of the adverse health effects that could come from this climate crisis. I want to call attention to something I know a number of the people listening have been working on this, that is something I think that we can be practically addressing and acting on in the clinic. And that has to do with the issue of extreme heat. We have seen that actually high heat is even more dangerous, I've heard, than severe cold. Over the past 7 years, those have been the hottest on record. And actually, I just read something that 2023 was actually the hottest year ever recorded. Climate change has either caused or worsened these extreme heat events. And in the last 20 years, there's been a 54% increase in heat-related mortality in people over 65. I'm not sure we're even checking the increase in heat mortality among workers. And 1/3 of the global warming season related deaths is now being attributed to climate change. I just want to refresh our memory, which I think is still pretty fresh. This last summer of 2023, as the hottest of the Earth, recorded the general Earth recordings that have been going on since 1880. I'm still pretty shocked by these pictures that were coming out, billboards that were advertising the Fahrenheit temperature in Phoenix, Arizona. I mean, 118 degrees. It's hard for me to even imagine that. I know how I feel if I even go out, it's 95 or 100. And I can't even imagine what it's like to be working under those conditions. I think some work had to be done at night, but this is really not really very compatible with a healthy work and in this situation. And so what workers are now at risk? And thinking about workers at risk for heat-related illness is really important. And one group of these workers is workers who are at risk because of the job. So if we think about it again, and you're free to write something in the chat or in comments or questions, here we certainly have that same group of outdoor workers, and that's exertional heat-related illness. Again, thinking about roofers, construction, road workers, landscapers, gardeners, anybody doing emergency response, firefighters, athletes, children doing sports, military, agricultural workers. They are all at an increased risk for heat-related illness. But by the same token, there are people who work indoors that we may not even be thinking about could be at risk for heat-related illness. Think about the kitchen workers, a construction worker, smelters, foundry. You may not think about it, but what about that remote software care worker who's working at home, but that home is on the third floor of a building in a not a very cool area, and this is a person who doesn't have an air conditioner. I'm also mechanical workers. I was trying to do some screening, which I'll talk about, that we were doing in the clinic, and I was speaking to somebody who I was doing driving a truck screening eval, and I said, oh, by the way, here's something about heat. Do you have any worries about heat while you're working? And he says, well, less so from the truck, but I work in the mechanics room doing some repair of the parts, and there's absolutely no air conditioning and cooling, and it's tremendously hot in there. So the other thing to be aware of is that the people who are doing these jobs are not all healthy 20-year-olds or whatever. The same workers who were doing many of these jobs that we've talked about actually have health issues. They could have diabetes. They could have a pulmonary problem, a renal problem. They could be very overweight or have heart disease, all conditions that could make them more susceptible to the stress of high heat. People who have mental health issues, maybe the medication that they're on, but just feeling even more uncomfortable on hot days, more irritable, sort of just pushing them over a little bit more into how their anxiety is doing, how their depression is doing. And then there are some medications which put people at risk. And so what actions can we, and also here is a heat.gov, another handy a site you can go to just to look at issues about heat and what OSHA and other places are doing, which, by the way, there are not national regulations to protect workers, which brings me to some of the responsibilities that I think we can be doing in the clinical setting. So what can we be doing? Well, one, I think it's education of ourselves to recognize the symptoms of heat-related illness. I have to say for myself, when I was reading through some of these things, I was less aware that just cramps in the leg could be an early sign, for example. And then in addition, this idea of having anticipatory guidance with our patients. What are the risks and what can they do? And some very practical advice here. So here, this was a fabulous article that came out in the New England Journal in 2022, which if you don't have it, it's really great to download it and keep it. And this article goes through and reminds us of some of these early clues about a heat-related illness, heat rash, cramps. So for those of us working in an ED or a urgent care, knowing that somebody coming in who might have some symptoms of just cramps in their legs or some swelling in their legs, taking an occupational history and finding that they're working outside and what conditions could be very helpful to identifying that this could be a heat-related problem and not just venous insufficiency. And therefore giving them some actions, which we'll talk about recognizing early a heat-related illness and taking measures so they don't go on to heat syncope, heat exhaustion, or heat stroke. This article also pointed out a nice graphic on the coexisting conditions, and I point to occupation and also medication and drugs, coexisting conditions, all of which could be at play with our patients who are working outside. And this is a handy list, maybe to have in the clinic or handily available. We were distributing this in our clinic so that people had it handy to know which might be the medications that could put patients at a greater risk for developing heat-related illness. So what about something practical in the clinic? So again, I start with what's your job, and just let the worker say what their job title is, but also what that job title involves. I mean, sometimes you think about a school crossing guard or safety or plumber. I mean, some plumbers are working indoors in a hot environment all the time, and some may not be. So just a few sentences, what's your job, and how do you do it? And maybe something even specific. Are you working or exercising under hot conditions? And if so, are they taking any measures to be able to cool themselves? And do they even know about heat-related symptoms? And what do you do when it's really hot? So a few questions to just fit into the practice. And then noting that this worker who may be working under a heat-related situation, just quickly checking to see if they have other risk factors. And here's where the practical piece comes in. There, if you haven't seen it, there's a great tool, the OSHA Heat Tool, which is an app that you can put on a smartphone, either an Android or an iPhone. And also giving people a handout. This is what the app looks like. And this is what we did in our clinic. I do work in an occupational health clinic, but we were getting some of our primary care places to do this too. And we're going to do this much more in the upcoming summer. We posted this in the clinic, and we had handouts to give to people. And then we also made a QR code for the OSHA app so that people could just download it right away in the clinic. And I had several workers, and actually healthy workers who also did a lot of exercise outside, download this app. And here's what it looks like. It calculates the heat index, taking into account both the temperature and the humidity. And then it will point to something saying it's a warning. And it works. It's for calculating your instant reading for where you are standing or sitting at that current moment. So it's very cool. And then the other good thing about it, because who can remember all the symptoms, particularly as a non-clinician, they can click right here on symptoms. Where is it? They have a symptoms here. Doesn't quite, yeah, healthy here, but to click on the bottom, it has a rolling thing of symptoms, which is very much like the New England Journal chart that I showed you, but in lay language. And it also gives first aid tips of what to do. And so this is, I think, something really useful, and you can have it just something that we're giving out to patients, and it doesn't take up that much time in the clinic. So just to summarize the interventions that we can do related to heat, I think we identify the patients who work in a hot environment, whether it's outdoors or indoors. And then these are very good guidelines. The heat safety tool. There's some great tip sheets that many of our colleagues here helped to develop, but that we just have them around in the clinic, and we are giving them out. And then we can consider some advocacy outside of the clinic regarding work and heat. And I have been concerned that actually some companies may not actually be implementing proper rules to help workers, such as taking breaks, coming out of the heat into a shaded area, drinking electrolyte type water. And this certainly came to my attention when I read this article. I think it was in the New York Times, noting that the Texas legislature had banned localities who had their own ordinances. That was Austin, and I think Houston had their own ordinance that workers needed to have a 10-minute break every 4 hours when the temperature and humidity was above a certain level. And actually this legislature thought that was a bad idea because it took time away from work and might hurt the businesses. And so there was no state regulation, and so localities would not be able to issue their own safety ordinance. Some of the Democratic opponents, so this is political, named this the Death Star. And shortly around the time, just before this was implemented, there was a worker who died of heat stroke from working outside under some of these really hot conditions. So I also checked to see, do we have a national standard to enforce that would require that companies put in some of these recommendations about breaks and providing fluid and a shady area. And it turns out we don't have a specific heat regulation. What this comes on is the OSHA General Duty Clause, which says that the employer is free to has to make the place safe for all employment and free from recognized hazards that are causing or likely to cause death or serious harm. I will tell you that the General Duty Clause, depending on what administration is in power, has less and less enforcement. So what about Massachusetts? What we have from our Department of Labor is encouraging words and recommendations to employers. Again, we don't have a law, so it's basically up to the employer. And there are responsible employers, and I definitely salute them. But I think there are many who, either through ignorance or just not caring, are not going to protect their workers. And that's why I feel that this is something that we in the clinic can be calling attention to and giving the workers themselves information that they can help to protect themselves. And frankly, some of the people we are seeing are small business owners, the painters who go out there, who I see for lead poisoning and scraping paint. They're out there as self-employed, and they may not even be aware of this. So also looking at another area of climate change, injuries, fatalities, mental health impacts. I think, again, this is another area where in our clinical practice, we can think about the workers that we see who are at risk. The emergency response workers, rescue workers, those workers who go out there during the snowstorms or the heat and have to replace the phone lines. Certainly, these are the people that we're thinking about, that we actually may be seeing in the emergency department or urgent care from injuries. But maybe we don't think enough about the transportation workers, the people driving the buses, who have to work extra hours because other workers are out, and having the mental stress of that. I mean, these essential workers, and thinking about those who might be at an increased risk for injuries. And I certainly would be concerned about those of our patients who have mental health issues, that this is just one more thing putting them over the edge. So what can we be doing in the ambulatory care appointment? I would just say, besides thinking about making the diagnosis, that we ask about the job, what is your job, and that we think about questions targeted to identifying those at risk and maybe trying to have more preventive actions. So my questions would be, what is your current or longest held job? And consider these workers who are going to be at an increased risk, particularly for air pollution and heat stress. I think those are two big ones that we can play a role in our clinical practice. And then using some time, just like we do for counseling, to counsel about air quality, giving people some practical advice, either as handouts or heat apps for the phone or websites and handouts. And just go back to my little chart, here. This is the starting point for me. For those of you who get more interested in this, I think also for diagnostic reasoning, some of our patients coming in, there are clues that some of their problems could be related to environmental factors. These are some handy questions that, what are the operating procedures? How do you protect yourself? What are the hazards? But to tell you the truth, sometimes the simplest thing is just to ask a worker, so what do you do for your job? And just give them a minute or two to just tell you what it is. And then you can think about what are their risks and what might be best to protect them. I do, by the way, have an outpatient clinic, and I'm also available for phone if you want to email me with questions, or you have a patient that you think has a work-related problem. I get many referrals from folks at Mass General and other places to help with the clinical decision-making and actions to take. So, in summary, I think we can be thinking globally about climate change, and we could be doing our advocacy, and yet we can still be acting locally. There are ways to act globally as well. I think many of the people who are part of this group are very involved with this. There is the Center for Climate Health and Global Environment at Harvard School of Public Health. There's also the Medical Society Consortium. There's a Physician for Social Responsibility. And I suspect that many of you have other organizations that you feel are really important for us to be able to deal with advocacy around climate, and feel free to put that in the chat as well. So I'm going to end there. I welcome people's questions or interchange and see what you all think about this.
Thank you so much, Dr. Goldman. That was incredibly comprehensive and very practical. I would love to start us off with a question. It's actually a two-part question. And you sort of answered it, but a little bit, but let me ask it anyways. Those two questions that you started with in terms of screening seem very intuitive and practical. And I'm wondering, if you're in an office where you don't have an occupational health environmental consultant, what do you recommend we do when somebody screens positive? And I'm wondering also if those are based on any evidence-based studies, or it's more expert opinion questions. And then a follow-up to that would be then, okay, specifically what resources, and actually Dr. Fury had mentioned one of the, when somebody says they don't have access to air conditioning, what resources have you used? Where do you refer patients to? So I'm sorry, that was kind of a long question, but
yeah. Okay, both are great questions. Let me start with the second one, because that's fresh in my mind. What we did in my clinic, I looked at the AmeriCare's situation. When we were starting to ask all of our questions, do you have a way to stay cool under hot conditions? And you're right. So then somebody says, well, no, I don't have an air conditioner. What do you do then? So there's several strategies. First of all, education, telling them about what the symptoms are for heat stress so they don't ignore it. And depending on the patient, I think this is the moment for some planning. I worry about some of the patients when I did primary care living on the 3rd floor, they couldn't get down. This is the time to say, okay, if it gets really hot, what are you going to do? It's not just putting a fan in the window, which is not great per se. To think about where could you go to be cool. And what I've heard is that, well, I think in Arizona they've had cooling stations, but that here in Massachusetts, that has not been a big avenue, but there's actual practical things. You can speak to a person. Where could you go? Could go to the library, but do a little brainstorming. Could you go to the library? Could you go to a shopping mall? Could you go to a movie theater? Could you go to your church? What about a family member who's got an air conditioner? So there's not a blanket thing for what you need to be doing for everybody about what to do. If you are living, by the way, in a not rent control, a title apartment that's subsidized housing, what I've done for patients when I was in primary care, I wrote that they had to give them an air conditioner as a medical necessity. I don't know if that still works. I put it on a prescription pad, and actually wrote letters to places, and also on bad air days, that this was a patient with really bad COPD or somebody who was in a wheelchair and they had to have an air conditioner. So I've been proactive on that front. Now, in terms of the much larger issue of what do we do when we find somebody who has an occupational environmental, or we suspect it. First of all, I think just starting the conversation, what's your job? And do you have concerns about risks? That does open a lot of questions beyond climate change. And there are some resources. I had a practical resource, not to advertise, up to date, but thinking about people who have certain symptoms like headache, think carbon monoxide or solvents, abdominal pain, and whatever the job is, think lead. So there were some practical associations that you could have, but sometimes, to tell you the truth, just asking the patient, how do you do your job, and how do you protect yourself? You actually learn a lot from the patient. And for example, with painters, they're out there scraping off old lead paint, and they tell you, well, I never wear a mask. I wear my clothes home. I mean, it's sort of practical to know that they should be doing something else to reduce their exposures. I think with the climate change risks, I sort of went over what I think could be some practical things that we could be doing in the clinic. And maybe this is something that we could, if this were some more questions about it, we could develop some of those tip sheets that EnviroCares. I would be happy to work on some if it were desired, tip sheets about this. I think my colleague over in pediatrics, Shalina Shah, actually has created some things about environmental risks and what you could be doing in the clinic. So I think we could develop that further. I don't know if that totally answers it or not.
I wonder if I can ask you just a follow-up question, particularly in relation to the kind of first part that you were discussing. My understanding is that Mass Health, which is Medicaid for Massachusetts to people who are not joining us from Massachusetts, that they have a program called the Flexible Services Program, where they provide coverage for certain like home improvements. And I thought air conditioning was one of them. I'm wondering if that's a program that you've ever used to try and, get kind of these essentially life-saving technology into people's homes.
I haven't. I'm not sure that was there when I was practicing primary care, but I did whatever the equivalent was, and I'm glad you brought that to our attention. I would just say for the people not in Massachusetts to check out what is available. And frankly, to have it posted in the clinic or easily available or part of your EMR, I think that's a really great point that you've made. These things are out there and we can advocate for it. I can tell you for air pollution, just as a sidelight, during the time that there was a lot of air pollution from wildfires. This isn't a worker, this was my sister, who has allergies and all kinds of stuff. I went and got a air purifier for her and sent it to her, and it made a huge difference. And along that vein, people like Josh Allen at Harvard School of Public Health, he's written a lot about practical air purifiers to have in the home or the workplace to deal with air pollutants. And it came out because of COVID, right? But actually, these same air purifiers, a lot of them work really well for particulates, to tell you the truth. And so putting more of these in schools, I mean, some of our patients, our workers, are teachers. And one of the things that came out during COVID was how bad the air quality was in some of their classrooms, right? And so a number of them put in these air purifiers. This is just sort of one example. I don't know if it goes with this. And to try again, it was more to protect about COVID, but frankly, these things also lower the amount of allergens, which, by the way, from climate change, we know that there's going to be more allergens because CO2 helps the plants that are binding it. They also make more pollen. And so there's going to be more allergy. So those kind of devices could be something practical, both for people that are working in a space that they, I mean, ideally you should have better air controls and better airflow. But as a backup plan, we could be recommending those kind of air purifiers. To your point, when how much research there is that asking any of these questions does any good, that's been the big obstacle, frankly, a lot of the time for being able to get these questions in there. But, you know, we're not, a lot of the time, we're not asked to provide data for why we ask certain questions. You know, sometimes there is data, you know, do you smoke? And we have counseling and all that. But for environmental or occupational problems, it's been sort of narrow, the ones where we really have some kind of data to show some impact. So it's a bit hard. And, you know, the meaningful use criteria to be able to get this question in the EMR has been an obstruction for over 20 years, since EMR first came out. Being able to have that data, although NIOSH has been working on it. Frankly, just as another sidelight on that, they were trying to get that in because where we do have data is on asthma. And so being able to ask a work question for anybody who has asthma, but it is one of the problems. So thank you, Greg, for bringing that up. And I would say for people living in other locations, check out what is available that you can write for, and then just do it and have it available.
That's great, Dr. Goldman. And you brought up a few things that some of our listeners have actually put into the Q&A. For example, when you brought up the indoor air purifier, one of the audience members was curious about actually indoor residential exposures, and brought the question about other types of issues like microplastics, and I'll throw in there PFAS. Is there any kind of evidence that these are affecting our occupational workers in terms of like maybe glyphosate and PFAS, microplastics, and other things that we don't typically think of?
Well, that is an enormous question for which each each component I could talk about a lot. Just the PFAS, if you haven't heard about it in primary care, you're going to hear more about it. These are these perfluorinated compounds that are put in a lot of things. They're fire retardants. The firefighters actually spray this stuff when you have an oil fire. It's sometimes in clothing. And what's happened on the PFAS point, this isn't air, usually it's much less air quality, it's sometimes, but it's more coming out in water, that people have found that it's contaminating their water. And now that we're able to measure in part per trillions, we're finding it in the water. And there's more research that is coming out about potential long-term effects. There's an excellent review of this that just came out because from a National Academy, which I can send to you and you can post later. And the reason I bring it up is there's been a controversy whether you should test people blood for any of these components, and there's pros and cons. We don't have time to go into it, but in the end, this National Academy report said, go speak to your primary care doctor. So of course, the primary care doctor may not have been up to date on all of these things. I have tried to put it some suggestions about that in some of the writing that I've done for primary care providers and around PFAS and some of those other things. The microplastics, another big deal. Boy, that's it also in our oceans, and we're just beginning to have some research out there about microplastics and our exposure to them, and wondering what could be the more long-term outcomes. Some of the plastics we do have data on, like the phthalates, and there's been a lot coming out in BPA, you know, the bottles, but that's another huge issue. Happy to talk about that at another date. There's just a lot. And I think, to tell you the truth, the second question that I ask, are you concerned about hazards or exposures at home or at work? I think listening to our patients, they may throw us a curveball that we don't know about right then, and to go look it up, because these things are coming out, as your person asking the question, fast and furious. I think the PFAS question should be on the radar now for primary care providers. It's a hot topic, as are the plastics.
Dr. Goldman, I think perhaps we'll just have time for one more question. And if I can ask you something about the medications, I think there's, you know, the list that we often see in terms of what increases somebody's risk of heat-related illness. And if a worker or somebody cannot find a cool environment, do you actually tell or advise clinicians or your patients to adjust the medications? I have found, like, let's take a patient who has heart failure. There's any number of medications on their list that affects their thermoregulation and hydration status. But I have yet to see hard evidence on like how we should be.
Oh, yeah, I don't think I would advise them to adjust their medication. To me, this is, I would be sitting down with this employee and going over the job in detail and saying, okay, what options do we have here? I would write a note to the employer if necessary. Because of health conditions, this person needs to take a break every hour for 10 minutes, has to be able to hydrate, whatever. It's, I regard that as not, you know, telling a diabetic or somebody with congestive heart failure to change their things.